Thank you very much, and I want to thank the organizers for inviting me to this wonderful country. I appreciate it. So it's a pleasure to present, again, the results of the NETTER-1 trial. Here's a disclosure page. So I don't think I need to explain to this audience how peptide receptor radiotherapy works. Let me just summarize briefly the fact that there have been several generations of radionuclides used. I would say that indium-111 is mostly of historical interest. I think there's still a debate on the relative merits of yttrium-90 versus lutetium-177 as radioisotopes. But I think many feel that lutetium-177 has the most favorable therapeutic index as far as efficacy and low rates of renal toxicity. With use of a somatostatin receptor agonist, you get internalization of the radiopeptide complex. Whether that adds to the cytotoxicity is a matter of debate. As you know, data on radiolabeled somatostatin analogs have come primarily from large institutional series, mostly in Europe, and several early phase clinical trials. And I think perhaps what's most striking is the median progression-free survival durations, which range from roughly 1.5 years to nearly 3 years in these series. And to put it in context, these are, in most cases, patients with progressive disease at baseline. And with that in mind, these are PFS durations that are much longer than what we typically see with conventional agents. That being said, until recently, there have been no randomized prospective clinical trials to evaluate the efficacy of PRRT. And so the NETTER-1 study was the first randomized prospective registration phase 3 trial designed to really assess the efficacy of PRRT with a high level of evidence. The population that was chosen for this study was patients with progressive midgut NETs, this being the most common type of malignant well-differentiated NET. These were patients who were required to progress on standard dose of octreotide LAR, 30 milligrams every 4 weeks. The investigational arm of the study was lutetium-177, given at 4 fixed doses of 7.4 gigabecquerels, followed by standard dose octreotide. And the control arm was high-dose octreotide, 60 milligrams every 4 weeks. And this was a control arm that was recommended both by the FDA in the United States and the European Medical Authority in Europe, simply based on the fact that there was no standard second-line therapy that was considered appropriate for control, and the fact that a placebo-controlled study was not considered feasible. The primary endpoint was progression-free survival by central blinded radiology review. And I think it's important to emphasize the central blinded aspect of this because this was an open label study. Secondary objectives include response rate, overall survival, time to progression, safety, tolerability, and quality of life. And I highlight the last objective simply because this is relatively new data, and while I'm sure many of you have already heard of the other results, perhaps the quality of life data will be a little bit new. So 229 patients in total were enrolled on the study, and you can see that the arms were relatively evenly balanced in terms of primary sites of metastases, and demographic criteria. The large majority of patients had tumors originating in the ileum, this being the most common site of origin for midgut NETs, and the liver was the most common site of metastases. Roughly 2/3 were grade 1 tumors, 1/3 were grade 2, and the majority of patients had very high levels of somatostatin receptor expression on octreoscan, which was required at baseline in all patients. Both chromogranin A and urine 5-HIA were also elevated in most patients, as expected for midgut NETs. So progression-free survival by central radiology review was the primary endpoint, and as you can see, there was a very substantial improvement in PFS with a hazard ratio of 0.21, which was highly statistically significant. Median PFS on the high-dose octreotide arm was roughly 8 months, and it was not reached on the lutetium arm of the study. This forest plot looks at various baseline prognostic factor, and you can see that patients seem to benefit from treatment regardless of prognostic subgroup, which included presence of extrahepatic metastases or not, elevated alkaline phosphatase at baseline, which has been a prognostic factor in several studies. Interestingly, there wasn't much of a difference whether they had very high levels or simply intermediate levels of somatostatin receptor expression. Obviously, patients lacking somatostatin receptor expression were excluded from the study. It didn't seem to matter whether they produced high levels of serotonin, chromogranin, whether they were grade 1 or 2 tumors, or regardless of age or gender. As far as objective response rate, it was 18% on the lutetium arm versus only 3% on the high-dose octreotide arm. And I think it's important to put this 18% figure in context. We're talking about midgut nets, which have really been a population of patients where we virtually never see objective shrinkage with conventional agents, whether we're talking about somatostatin analogs, targeted agents, or cytotoxic chemotherapy. So in light of that fact, actually seeing tumor shrinkage with a systemic agent is quite unusual. Overall survival is clearly an important endpoint. There were 26 deaths at the time of data cutoff on the control arm versus only 14 on the investigational arm, resulting in a hazard ratio of 0.4 and a p-value of 0.0043. Although it's important to emphasize that this is only an interim analysis of overall survival, and therefore the threshold for statistical significance had a lot of zeros behind it. So on a very technical level, this is not yet a statistically significant finding, although I think it's very encouraging, and hopefully we'll see a statistically significant improvement in overall survival on final analysis. What about side effects? You see here when we look at all grade nausea and vomiting, the numbers are substantial, but when we look at grade 3 or 4, they're not that high. Much of this reflects the amino acid formulation that was used during the trial, which was basically commercial formulations of roughly 18 to 20 amino acids, as opposed to the modified formulation of arginine lysine that's typically used in Europe, and that's really not nauseating. So when you use these large number of amino acids and infuse them at a high rate, patients get quite nauseous, and the nausea goes away once the infusion is stopped. As far as cytopenias, we saw relatively low rates of grade 3 or 4 leukopenia and neutropenia, which is encouraging. Lymphopenia seems to be more of a finding on laboratory reports, but the clinical significance is probably marginal, given the fact that we really don't see any opportunistic infections with this therapy. And this is just miscellaneous other side effects, which were really not that prominent on the trial. Renal toxicity has been a concern in the past, but at this point, we're really not seeing any evidence whatsoever of nephrotoxicity on the trial, although, the median follow-up was only about 1.5 years at the time of the data lock. When it comes to bone marrow toxicity, I think it's clear based on large institutional series that the risk of leukemia/MDS is probably in the 1% to 2% range. I think it's premature to know what the outcome will be from the NETTER-1 study, so that's something that we need to look at with long-term follow-up. So what about quality of life? This is a very preliminary look at quality of life. The analysis is still being done. All patients filled out the EORTC QLQC30 questionnaire, which is the generic cancer quality of life questionnaire, as well as the EORTC 21 question survey that's specific to NETs. And so we chose for a preliminary analysis to look at 4 domains that we considered most pertinent to midgut NETs. So one of them is global health status, which is of course common important domain for any cancer therapy. And this simply asks 2 questions. How would you rate your overall quality of life, and how would you rate your overall health? And it summarizes it in a 1 to 7 scale, and then it's converted to a 0 to 100 scale. And the way we presented it is based on clinically significant, greater than 10-point changes from baseline. So on the bottom, you see improvement on each arm of the study at various time points, and on the top, in blue, worsening. And what you'll notice is that at virtually all time points, you have more improvement with lutetium than octreotide and less worsening with lutetium than octreotide. And in fact, on average, 28% of patients reported improvement in their quality of life on lutetium versus 15% with octreotide, and 18% reported worsening versus 26% with octreotide. And this was actually statistically significant at several time points. Diarrhea is also obviously an important component for midgut NETs. And again, you see a similar trend. The diarrhea on average improved in 39% of patients in lutetium versus 23% with octreotide, and worsened with 19% of patients on lutetium versus 23% with octreotide. And this was statistically significant at one particular time point. We also looked at pain. Again, a similar trend. It improved in 41% of patients on lutetium versus 28% on octreotide, and worsened in 27% of patients versus 25%, although this was not statistically significant. And with flushing and sweats, which asks, it's a NET-specific question, which asks both whether patients are experiencing flushing or sweats versus, and also whether other people observe flushing. In this case, there was no particular trend. There was actually improvement really on both arms of the study, indicating perhaps that patients with high-dose octreotide may experience improvement in their carcinoid syndrome. In this case, we could not say that lutetium was necessarily superior to octreotide in this particular domain. So to summarize, the NETTER-1 study was the first prospective randomized phase 3 study of radiolabeled SSA. The results were quite compelling in the sense that it showed a marked 79% improvement in progression-free survival, which was highly statistically significant, a very significant improvement in response rate, and a very encouraging, let's say, trend in overall survival improvement that needs to be confirmed on final analysis. The safety profile seemed to be quite favorable, and particularly notable was the fact that we saw no real trend towards deteriorating renal function with use of amino acids. We saw consistent benefits across various prognostic subgroups, and this preliminary look at quality of life suggests evidence of benefit in QOL domains that are important to patients with midgut NETs. Thank you.
Thank you very much for your presentation.
Thanks.
We can take a few questions from the floor. Professor Hicks.
So, Jonathan, welcome to Melbourne.
Thank you.
Nice to have you here. I never presume to read the mind of the fairly dumb organisation in your country, but how could they not allow a placebo-controlled trial when they'd done one for Radiant 3 and Radiant 4 and the sunitinib trial, the data in this trial shows a significant stabilisation of progressive disease in the patients on the control arm. They were progressive beforehand. If you look at the percentage of patients who had stable disease by RECIST on the follow-up, it was 70% odd in each arm. And so that suggests, like the Clarinet study, like the PROMID study, that increased dose somatostatin analogue in itself has a progression-free survival advantage. Although we don't have randomised controlled trial, it's a reasonable assumption based on this. So do you think, my question is, do you think that we're perhaps underestimating the benefits of radionuclide therapy in this population by actually testing it against what is very possibly an active arm in patients with progressive neuroendocrine tumours?
Right. Well, I mean, I think the results are already fairly compelling. So, you know, you don't typically, at least in oncology, see this kind of hazard ratio. So I think, you know, even if the results might have been slightly better with placebo control, they were pretty good with high-dose octreotide control. I should have probably had a slide on the eligibility criteria, but the eligibility allowed required RECIST confirmed progression at baseline to enroll in the study, but that progression could have occurred over a period of as long as 3 years. So I think it's hard to say what impact the high-dose octreotide had on disease stabilization. I think it had some in several patients. I mean, there was a 3% response rate. One of those patients was mine, and that response was real. But overall, it's hard to say that the impact of high-dose octreotide seemed that substantial. I mean, it's hard to say because, you know, we don't know what the response rate would have been. I think, you know, you would have on standard dose octreotide. I mean, you need to maintain these patients on octreotide because of carcinoid syndrome. So I don't know how much difference it would have made if it had been a true placebo-controlled study. I think that was considered to be both logistically difficult, given the fact that, you know, you have to, you know, provide these amino acids, you know, check for radiation. It would have been difficult to keep it truly blinded. And there's always a concern about patient enrollment on a placebo-controlled study, although now we know that patients do consent in many cases to enroll in a placebo-controlled study.
Yes, hi. So following the initial interim data analysis, for patients on the control arm, just wanted to clarify if there was actually crossover allowed.
There was no crossover.
No crossover was allowed, okay. And then are you gathering data on subsequent lines of treatment following initial disease progression? Because that potentially could impact on the final data on overall survival. Right.
I don't have this data right now. I mean, I think we probably will have that data in the future. I can say that more than a few patients did cross over to receive peptide receptor radiotherapy at different places off trial, which of course might impact you know, the overall survival results on the control arm, although I suspect that was a relatively small minority.
Yes, I was interested to see the quality of life information there, but I noticed there wasn't any slide on fatigue. Did you measure that at all?
Yes. Yeah, this is just a preliminary look at the quality of life data. We're hoping to present a complete picture of the quality of life maybe at GI ASCO this year.
Could I follow up on that quality of life? The instruments that we've had for looking at quality of life, particularly neuroendocrine tumours, have been very blunt, and there's been a specific one for neuroendocrine tumour from the European Nuclear Society, and that's been deemed to be also not refined, and is in evolution now. With the advent of PROs, patient-reported outcomes becoming admissible to regulatory agencies. How are you, in your assessment of quality of life, collating those patient responses so that they make some sense and can be calibrated in some way?
I'm not sure I understand the question. I mean, I know that, for example, in the Telestar study, they conducted patient interviews. Is that sort of what you're referring to? Right. We didn't have, we didn't have that particular methodology. The NETTER-1 trial went with very conventional EORTC quality of life questionnaires. Having a sort of a validated, standardized questionnaire probably adds to the credibility, but maybe there's room for other approaches.
Well, in the literature in the Journal of Clinical Oncology particularly, there's a tendency for oncologists, especially in clinical trials, to underestimate the impact of toxic side effects on their patients, and to talk about manageability rather than the way in which the patient perceives the toxicity. And the other thing that is becoming more and more discussed in the oncology literature is the issue of financial toxicity. And we should address that as well. And I just wonder in what ways you're addressing those patient concerns which come up at all the patient fora that I've attended.
Well, I think it's hard for a clinical trial to measure financial toxicity, although I think that's one of the EORTC questions, given the fact that they're receiving medication free of charge on the study. So that would be hard. It would be hard to to analyze the real-world impact of financial toxicity in a clinical study population.
Are there any other questions? If not, I have one question.
Sure.
You noted on one of your slides that a few patients had Crenin 2 uptake, which were subsequently enrolled into the trial.
Yes.
What was your inclusion criteria? Because I think
Crenin 2 and above.
2 and above.
Yeah.
Okay, so the uptake is quite borderline. Do you think those patients would have a less likelihood of responding to PRRT given the uptake wasn't very high?
Well, when we looked at the subgroup analysis, it didn't seem to impact benefit. So it's hard to say. I mean, certainly there have been other studies that show a correlation between the Crenin uptake and at least objective response rate. As you know, Octria scans are, can sometimes be quite crude. Maybe with a gallium-68 scan, we'll be able to really get a better sense of who is most likely to benefit versus not.
Are there any other questions? Not, I'd like to thank you for your presentation. Thank you very much.
Appreciate it.